It's the only reason to go.
It just means I can celebrate through the entire weekend.
You can have multiple fun dresses and whatnot.
Yeah.
Yes, one just for the wedding, which you can't wear your birthday dress for the wedding.
And Saturday, I go to Charlie's Steakhouse. And we get a Giants cake.
I said, not your birthday suit, man. And I say suit.
Oh, I decided all of the things.
Wait, no.
Yeah, I do one of those.
I was like, wait, oh my.
I just decided I'm gonna get the 36-ounce ribeye or the 42-ounce T-bone. But I need the protein.
I love it both.
Ribeye.
Y'all ready to start? What questions do we have after yesterday? Any? No?
Everyone else got one Saturday. I do have a question, I just can't find it. I made a note on my notes.
Okay.
That's what I've been looking for.
Okay. Yes, sir.
Do people with hemophilia have a reduced risk for embolic disorders?
For what?
Embolic disorders,
Yes.
stroke, PD?
Yes. Because their blood does not clot very easily. So yes, they're rare, probably never on blood thinners.
Yeah.
What's that?
So also in regards to hemophilia, so they have that lower factor 8 or 9, and you said a low PTT, but I found some stuff that's saying high PTT. Okay, because you said low yesterday, so I just wanted to confirm.
Like longer. So long PTT.
Elongated.
Yes.
Right, okay.
I misspoke.
All good.
It is long. Anything else before we start? So we're going to start with just a very brief overview of a stem cell transplant. As I said yesterday, this is for the sake of this class, the only cure for sickle cell. There are new things emerging, but at this point, yeah, this is your cure for sickle cell. And then our leukemia patients, a lot of times, that's what stem cell transplants are done for even more often than in sickle cell. So in a stem cell transplant, you can have 3 different kinds. Either the patient can donate to themselves, so they, through plasmapheresis, their blood is taken out of their body. It's treated to get rid of whatever the problem is, the sickled cells or the cancer cells. Their bone marrow is also treated. They get chemotherapy and radiation, and then the stem cells are put back into their body. That's not super common because we're trying to actually change the stem cell. So That's not really common, especially in sickle cell, because it is a hereditary. So it's still going to be on the genes of those cells. That's called an autologous transplantation. Autologous. An allogeneic is where there is a donor involved. The donor can be identical, an identical twin. That's syngeneic. And then if it's not syngeneic is the same. The other type of donor is just a random donor. Typically, they try to find a sibling because the sibling would be the more closely related to the patient.
What do you call the other one?
Syngeneic, syngeneic, is the
Not that one.
not the other one. That's just a donor. There is a name for it, but I don't have it in these notes, so I'm not going to tell you. I'm also not going to ask you. That's the most common, though, is where there is a donor involved that is not an identical twin, because not a lot of us are walking around with identical twins. So that's the most common. So what is done is it's plasmapheresis. They take the blood out of the donor. They do have to find someone who's closely matched. So they do try to do usually siblings, because siblings are going to be the most closely matched because they have DNA from the same parents. So not half siblings or step siblings. What they do is they look at HLAs, which are human leukocyte antigens. They are on the cell walls. They're antigens on the walls. And the more HLAs that we have that match, the least likely the accepting patient is going to attack it, basically, or reject it. Okay? Unrelated HLA-compatible donors are used when a family member is unable to donate. But like I said, we try to do family members. Some parents will actually conceive to give their kids a donor. Jodi Picoult wrote a book, My Sister's Keeper, which is a really good book. But the little girl was conceived to save her sister's life. So it's interesting. So stem cell transplant, basically, it is an IV infusion. You'll need to know that. It's an IV infusion. So the blood is taken out of the donor, and then it is infused into the recipient via just a regular IV. It is very similar to a blood transfusion. Okay, so what happens is the patient who is receiving this stem cell transplant, their bone marrow will be treated with chemo and radiation to kill their bone marrow. We want to totally eradicate all of their cells and then infuse this new bone marrow these new stem cells into the patient's body, and then they go to the bone marrow and they start making blood cells. Okay? Like I said, it's just a regular IV infusion. The patient, when they have all of their bone marrow taken out and killed, they have basically essentially no bone marrow at all for 7 to 10 days. So we kill all of their ability to make blood cells. They're obviously going to be in strict isolation, because if we're killing their ability to make blood cells, they're not going to have white blood cells, red blood cells, or very, very low numbers of white blood cells, red blood cells, and platelets. So they are in strict isolation. They typically can have a parent in the room with them. They cannot have multiple visitors. The nurse that's taking care of them cannot be taking care of a patient who has some kind of communicable disease or something that can be spread to this patient. At Children's, they're in the oncology unit, and they're only taken care of by oncology nurses who only have other oncology patients with immunosuppression. Because if you think about it, they don't have red blood cells, white blood cells, or platelets. They can't do any of the things that your blood's supposed to do. So they're anemic, they can't fight infection, and they will bleed easily. So what that is called is pancytopenia. Pansy means across the board, topenia. So across the board, the blood cells are low. So during this time, we're going to watch for bleeding, anemia, and infection. Our main concern once the patient gets the infusion is going to be graft versus host disease. That is the most common rejection, basically, that the patient will have. This is a picture of it. It starts as just a rash, but it proceeds to be much worse, which we'll go into. But I just wanted to show you a picture. So we want to monitor the patient for any signs of rejection, specifically graft versus host disease. You're going to assess the skin and the mucous membranes, the GI function, the respiratory function, the cardiac function, and the hydration status. This graft versus host disease can happen anytime. It can happen while the patient is still in hospital until after they're discharged forever. So they are always at risk for graft versus host disease. Typically, it's going to happen within the year of receiving the bone marrow. But they still have a small chance of it happening beyond that. After the transplant, our care is going to focus on preventing infections still, because they get the transplant, they remain in isolation until their body gets to a normal white blood cell, red blood cell, and platelet count. Okay? And that usually takes like 2 to 3 months before they're at normal levels. Okay? I don't want to misquote how long it takes before they start. If the body accepts the new bone marrow, it'll start making new blood cells in 2 to 4 weeks. Okay? So this patient is in isolation. It is a very lengthy process because we put them in isolation. We remove their ability to make blood cells. We take their bone marrow out. Then we wait 7 to 10 days, and then we infuse them with the new stem cells. And then 2 to 4 weeks later, their body actually starts making blood cells again. So it takes a while for the body to build up to what's normal levels. Okay, so our care is supportive at that time. So we want to prevent bleeding. All of the things for the bleeding disorders. We're going to minimize needle sticks. We're not going to give them aspirin. All the things that we talked about yesterday. For the anemia, we're going to expect them to have weakness, fatigue, pallor. We're going to give them iron-fortified foods, a well-balanced diet to help them build up their red blood cells. And then we're going to make sure that we are doing proper hand washing, have them in the strict isolation so that we don't spread anything to them. Also, this is a lengthy process. We have to provide supportive care. The parents, typically one of them, if there are 2 parents involved, or if there's a single parent, typically somebody's in the hospital with this child. So someone's not at work, basically. So social services is usually involved. And then if there's no parent in the room, well, then the child's all alone in strict isolation. So they're going to definitely need support. Imagine an adolescent who's used to being with their peers. All of a sudden, we take them out of their environment. We put them in a hospital room for 3 to 4 months, and they can't see anybody. So it's pretty stressful. And also, we don't do stem cell transplants at every hospital. So if there's a child who needs a stem cell transplant in the southeast region of the United States, they could be at Children's Hospital. So the people could be 8 hours away from their house at Children's Hospital receiving this. So it's definitely a very stressful time for these families. And then if there's other kids too, the siblings can't come visit their sibling in the hospital. And a lot of times siblings are close. So it's stressful. They need a lot of support. Before discharge, we have to educate. We have to educate on the risk of graft versus host disease for the rest of their life, but specifically what signs to look for, which we're going to get into next. Infection control, bleeding, just signs to watch for of all of the blood count starting to go down again. We're going to educate the parents and the patient. So, we talked about this. This is the graft versus host disease rash that I showed you. So, graft versus host disease can range from mild, which is just the skin rash, and mucositis. They may have the sores in their mouth, fever, and the first blood count that starts to drop is the white blood cell count. So, they're going to be first at risk for infection again. It's going to be important for the rest of their lives. They do need to make sure that they do take precautions to not get sick. They don't need to completely isolate themselves, but if they're going to be in large groups, they may want to wear a mask. They need to have proper hand washing. They are going to want to cook their red meats like done. They don't want to eat rare meats. They probably don't want to eat sushi. If they're going to eat fresh fruits and vegetables, they need to wash the fruits and vegetables for 5 minutes underwater. Those are all precautions that we tell cancer patients to take when they're under chemotherapy, receiving chemotherapy, because their white blood cells are low. So they're going to have to take all those same types of precautions. If they have a severe graft versus host disease, they could have GI bleeding and sloughing, pancytopenia. Remember, pancytopenia is across the board, low blood cells. And then multi-system organ failure. Basically, the organs just start shutting down because they're losing their blood cells. And so their organs are not getting oxygen anymore. Okay, so what we need to make sure that we show the parents or the patient the skin rash of graft versus host disease, so they know as soon as they see that to get the child in, because the child's going to need steroids, anti-rejection medication, and basically we have to kill that bone marrow again and try another bone marrow stem cell transplant. They are also at risk for vaso-occlusive crises. I talked about infection, fluid and electrolyte imbalances, and then any side effects of long-term side effects of chemo and radiation. That can be like paresthesias, numbness and tingling. From radiation, they can have basically it's like a sunburn to the area, the thick skin. So they're going to have long-term sequelae from having the stem cell transplant. I said infection is a concern. It is a major cause of death in the patients who receive this. It's not just leukemia in the patients who receive a transplant. Sepsis is also common because their white blood cell count is very low. This is like through the whole process of the infusion. This is not just if they reject it. Okay. The three most common sources of infection are the skin. So we want to make sure they're having proper skin care, that they're checking their skin. They're checking the bottoms of their feet for the small cuts, cuticles, things like that. Respiratory tract, they need to make sure that if they are in large crowds, they're going to wear the mask. Things like that to protect their respiratory system. And then the intestinal tract, those were the things that I told you about, the fruits and vegetables, the meat, sushi, things like that. The gram-negative bacteria are the most common cause of infection, but obviously anything can cause an infection. Do y'all have any questions about stem cell? No? All right. So we are going to do a case study. Y'all are going to have to wake up and talk some. Y'all ready? I'm going to try and get through this so y'all can take a short break before Miss Matthews. She's going to come in at 9 and do infection. Were y'all aware of that?
Yes.
My last group was not aware of that, and they were upset with me. It wasn't my fault, though. So, I am going to, after I do this with Team 3, I will post this PowerPoint on Canvas. I just wanted to go through it with everybody before I posted it. So we have Hope Hall. She's a 7-year-old African-American female with a history of sickle cell disease. She was at a medically monitored summer camp and participated in several sports activities. The camp was in New Orleans. And she began having pain in her right knee. She was a direct admit to the pediatric floor of the community hospital. You are her primary nurse, and she weighs 48.5 pounds. So what in this is pertinent? What's going to get our attention? She has sickle cell. What else? There's some mumbling. Her knee. Sports. Where is she?
New Orleans,
In what season?
summer.
So, what are some common? What's probably going on? What do you think?
Probably dehydration.
Yes,
Vaso-occlusive.
vaso-occlusive crisis. So the things that have contributed to this vaso-occlusive crisis: dehydration, we said, heat. So we talked about if someone's body is hyper or hypothermic, basically. So she's probably a bit hyperthermic if she's been playing outside in New Orleans in the summer. Right knee is probably the location, I think somebody said. Medically monitored camp. You think that means anything to us?
Yeah,
What?
that she has an underlying disease, or she's at a medically monitored camp.
So she knows she has sickle cell. Her parents know she has sickle cell. But she's probably compliant. Because if you're going to take the time and use the resources and money to find a medically monitored camp, you're probably more on top of your child's care than someone who's not going to do a medically monitored camp, right? And then also she's a direct admit. So what do y'all think that would indicate?
She's already got a physician that she's contacted.
Physician, and she's probably what we would call a frequent flyer. She gets to bypass the emergency room because it's happened. Basically, they knew what was happening. They called the doctor, and the doctor just direct admitted her, right? And then, obviously, when we have a pediatric any patient, but specifically pediatric, we want to know their weight, usually in kilograms. So do y'all know how much she weighs in kilograms?
24-ish, yeah.
22. So here's some more information about her. She was diagnosed with sickle cell anemia at birth during a routine newborn screening, so they've known about it since she was born. She was a term newborn with normal childhood illnesses. She's been hospitalized with pneumonia once at age 6. Although now she's up to date on her childhood immunizations, she only recently became current with her pneumococcal and influenza vaccines. She has had multiple hospitalizations for sickle cell crises and transfusions. She lives with her mother, who is 32, her half-brother, who is 18, her brother, who is 6, and her mother is currently 6 months pregnant. They live in a 3-bedroom, 1-bath home with all utilities. They have an automobile, but it's not reliable. So what sticks out to us here?
She just came up to date with her vaccines. She does have a brother, a full brother.
It doesn't say whether that brother is.
We don't know anything
Also-
about him. Yeah, we don't know if he has the
Yeah.
sickle cell or the trait or anything.
They all share one bathroom.
Why is that pertinent?
Infection.
Do we think this 18-year-old brother and 6-year-old brother are always very clean?
No.
So, especially the 18-year-old brother could be bringing who knows what kind of organisms into the bathroom. And then the 6-year-old brother, I haven't potty trained a boy yet, but I don't think they have really good aim at 6. It's terrible. I've done 4 girls.
They pee everywhere but the toilet.
I get to experience that in a couple years.
He's not forgetting yours. Boys in there at 6. She's had multiple hospitalizations.
Frequent flyer.
Definitely a frequent flyer. And she's even had a lot of blood transfusions. So we might question whether or not she's actually compliant. because of that.
Well, if the mom is working with 3 kids at home, she's probably I should say, let me rephrase that. The mom has 3 kids at home, she's probably working,
Uh-huh.
which means she is probably less compliant,
Uh-huh.
which is probably why she's been in the hospital several times.
Uh-huh. And mom is,
Pregnant.
she's about to have number 4. She's a little
God bless her.
distracted. There's something else that's pertinent that would have to do with medication compliance and compliance. Transportation. So she may not actually always make it to her appointments. So while I said in the last slide we can assume that she is compliant because she was at medically monitored camp, maybe a social worker set that up or something. So because mom probably doesn't have the means or wherewithal to even really provide the care that Hope needs. Because she's got a lot going on. So, let's see. Make sure I covered everything. Hopefully now that she is current with her pneumococcal vaccine that should prevent any more pneumonia. Do you guys remember what can happen? It doesn't mention that she had this complication, but with pneumonia, what is the complication that it can lead to?
Chest. The acute chest? No,
Starts with an S.
not the chest.
Say it louder. Somebody said it. No?
Sepsis?
Sequestration crisis. That is where the body is shunting all the blood to the spleen. And that is common after pneumonia. Okay, so we didn't mention that, but we're definitely going to, in our assessment, going to want to palpate her spleen to make sure that she doesn't have an enlarged spleen. And then the other risk of having pneumonia would be acute chest syndrome, which again, it doesn't mention that she has any history of that. It's just the vaso-occlusive crises. What is the leading cause of death in sickle cell patients?
Infection. No.
What specific?
Can you repeat the question?
The leading cause of death in our sickle cell patients. She doesn't have it at this point. I'm just wondering. Acute.
Chest syndrome.
Mm-hmm. Very good. So here are Hope's vitals. Her temp is 99.4. Is that alarming to us? No. Why are we not alarmed about that?
It's not fever.
It's not a fever. It's elevated. We expect some elevation because
Inflammation.
she's in pain and she has inflammation. Exactly. Her pulse lying as 103, standing as 142. Is that alarming?
Yes.
Yes.
Orthostatic.
She's orthostatic and she has basal tachycardia. When she's at rest, she's 103. So what do we think is maybe going on? Dehydration. What else?
Hyperthermia.
What about the blood pressure? 99/52.
Orthostatic.
She is definitely orthostatic and dehydrated and anemic, probably. Right? Her body's trying to get that blood flowing, whatever blood she has. Are we concerned about that respiratory rate? No, we're not. Normal respiratory rate for a 6-year-old, 7-year-old. Is she 6 or 7? It's 18 to 30. She's 7, right? Yeah. So she actually, while it's elevated, it's on the high side of normal, it is considered normal because it's under 30. Okay, an increase in the heart rate of 20 beats or more, or an increase in the systolic blood pressure of 20 points or more, that is diagnostic of orthostatic in a 7-year-old. It is definitely an alarming finding. So we need to definitely address that. She does have orthostatic dehydration probably. O2 sat, are we concerned about that O2 sat? So is the first thing we're going to do is put oxygen on her? No.
Treat the pain.
So her PQRST pain assessment, I cannot talk right now. Movement and weight bearing is what is provoking the pain to her knee. Rest, elevation, and warm compresses are palliative, are improving the pain. Are we okay with putting warm compresses on her? Yes. We just don't want to do hot compresses. Quality, my knee is really hurting. It's a deep ache. That is how sickle cell crises are described. It's her right knee.
It's most likely in the joint, so it's
Yes.
going to be deep.
Yes. Heat. And what is our rest, elevation, and heat going to do to it?
Vasodilate.
Vasodilate. And it's constant since around noon today. So just with this information, she's having sickle cell crisis because sickle cell pain does not come and go. It is constant. It's a constant ache because there is a occlusion in her joint and the blood vessels of her joint, and that's not going to go away until we actually get those sickled cells unsickled. How do we unsickle sickled cells? Oxygen. All right, so here is our assessment. She is uneasy in bed. She's changing position frequently, but she is cooperative and does respond to questions appropriately. So what is the general appearance tell us? She's uneasy in bed and changing positions frequently. She's in pain, she's uncomfortable. I don't know if you remember from yesterday, one of the precipitating factors of a vaso-occlusive event is emotional stress. She's feeling some emotional stress, probably from the pain. She could also be upset because she had to leave her friends at camp. So we need to make sure that we address her psychosocial. That's not going to be our primary, most important thing, but we definitely need to address that. Respiratory. Breath sounds are clear with equal aeration bilaterally. Unlabored respiratory effort. No nasal flaring, no tracheal tugging, and no retractions. So are we good with that? Mm-hmm. We are relieved because we're not dealing with acute chest syndrome. Okay? Because remember, anywhere that there is blood flow in the body, we can have a vaso-occlusive event. And just because there's a vaso-occlusive event that we know about in the knee, it could be anywhere else as well. So we're relieved that we're not dealing with her chest. Cardiac. She's pale, warm, and dry. No edema. Heart sounds regular with no abnormal beats. Are we relieved about that? No abnormal beats? Because if there were cardiac changes, what kind of cardiac? If there were a murmur or a S3 sound. Why is she pale? She's probably anemic. So we're going to assume that until we get to the CBC. Pulses are +1 × 4. How do we feel about that?
She's hypotensive.
She's hypotensive, so that's why they're only +1, and she's probably dehydrated and anemic. But we're also relieved that her right pedal pulse is equal to her left pedal pulse because she is having some kind of vaso-occlusive event in her right leg. But obviously, she's still getting blood to her feet. Equal palpation, all that. Denies chest pain. Neuro, she's alert and oriented to person, place, time, and situation, but she's exhibiting signs of fatigue. Are we concerned about that?
It's expected.
It's expected because she has hypotension, anemia, dehydration. All those things cause fatigue. We're relieved that she's oriented ×4. Probably not dealing with a CVA either. So we're at this point thinking it's just localized to her knee, which we can deal with. GI. Remember, what did I want to palpate in her GI? Her spleen. So her abdomen is soft and non-tender, so we're good. Bowel sounds are audible, proscultation in all 4 quadrants. She is voiding without difficulty. Her urine is clear, dark amber. Why is her urine dark amber?
Dehydrated.
She's dehydrated. What is another reason that it could be dark amber?
Proteinuria.
She's taking that
No, she's not taking that medicine yet.
Bilirubin.
Billy. Very good. So she is in a crisis, a vaso-occlusive crisis. So she's going to have increased red blood cell destruction. Byproduct of red blood cell destruction is bilirubin. The body's trying to get rid of it. So, but she's also dehydrated. So they're working synergistically to make her urine darker. Skin is intact. We're good about that. We're glad she's not developing an ulcer because remember we want to inspect the legs, especially lower legs, for ulcers. So she has an event in her right knee. Her skin is still intact, which it usually takes a lot longer than a couple of days for you to develop an ulcer. Musculoskeletal, her right knee is swollen. Are we expecting that? Yes. Erythemic, warm to touch, decreased range of motion, and pain reported with movement. Do we want to immobilize this knee? No. I don't want y'all to get confused with hemophilia. In hemophilia, we would immobilize the knee. In sickle cell crisis, we're not going to immobilize this knee. We want her to move it. It's going to be painful to move it. So we get the warm compress. We get the pain medicine as soon as we get it ordered. And we start moving this knee. All right. Make sure we got everything on this. And then also because she's dehydrated, we want to decrease hemostasis. So another reason to move the knee. All right. So here's our labs. So she, I guess, was in the clinic 3 weeks ago. And her red blood cells were 4. Her hemoglobin was 10.2 and her hematocrit was 34. Is that alarming for a sickle cell patient? No. This is that's her baseline, most likely. Yes, it's low, but we expect our sickle cell patients to live a little bit lower than normal. So it's probably her norm, and then all her white blood cells and platelets are normal. Her reticulocyte is 2.3. It's a little elevated. Is that alarming? No.
No.
Why are reticulocytes elevated?
She's producing red blood cells.
Yes. Her body's trying to compensate for this 10.2 hemoglobin that she probably lives at. So that was 3 weeks ago. Well, today, her red blood cell has dropped to 2.9. Her H&H is 7.6 and 25.2. So are we alarmed about that? Mm-hmm. Yes. So she is probably going to need a transfusion. Because, why is she going to need a transfusion?
Her reticulocytes are low.
Her reticulocytes are low too. Her body's not, it's basically all of the reticulocytes that it's put out have already matured and it just cannot keep up to get it back up to normal, to get her red blood cell back up to normal. Why do we need red blood cells in this specific instance? She needs oxygen to fix the occlusion. We need oxygen. What is going to take our oxygen to the occlusion? So putting oxygen on her is not going to really do anything because we need carriers for that oxygen. So we're going to expect that the doctor is probably going to order a blood transfusion. Okay. So here are our orders. She's diagnosed with sickle cell disease with vaso-occlusive crisis. She's admitted to the hospital. We know that she's a full code. Vital signs per routine. Are we okay with routine vital signs or do we want them more frequently?
Until her blood pressure normalizes.
We're okay at this point because it's not critically low. If it starts to become critically low, then yes, we'll want it more. But we're going to keep reading. We're going to assume that one of these orders is going to fix that blood pressure. So at this point, we are okay with it. If anything was critical, then we would want it more frequently. Regular diet. So CBC with DIF, CMP, retic count, QAM. We know why we want a CBC. We know why we want the retic. Why do we want the CMP? Make sure there's no organ involvement. What specifically what organ?
Liver, kidney.
Mm-hmm. So because we want the liver to be processing this extra billy, and we want the
to
kidneys,
treat.
the billy, and make sure that they're not compromised too. Okay, normal saline bolus, 500 mils. Are we happy with that?
Yes.
Yes. And then after that bolus, she's going to be on these IV fluids, D5 half with 20 of potassium at 64 mils per hour. It's unusual that we're going to be giving her potassium because we don't know her potassium. So I would probably, if I saw that, say, are we going to check? Maybe ask the doctor, do you know the potassium level? Or a respectful way of saying, can we make sure that her potassium is low? Because if it's elevated with the dehydration, then that's going to cause a problem, right? So we definitely want to question that respectfully. And then 64 mils per hour, a 22 kilogram patient. Do you guys remember maintenance IV fluid equation from way at the beginning of the semester? So for the first 10 kilograms, you get 100 per kilogram. And then the second 10 kilograms, 50. And then 20. So that is per day. And then you divide that by 24, and the answer is 64. Why is she on folic acid? Red blood cell production. Folic acid is going to help her make healthier red blood cells. And she needs some help making some red blood cells right now. Why is she on penicillin V potassium? Prophylactic. And we know that we're not dealing with an infection, or we can assume we're not dealing with an infection right now because her temp was only 99, whatever. So she doesn't need to be on anything stronger. Her prophylactic antibiotic is going to be enough for right now. Ketorolac. Pain. And what do you remember about ketorolac? It is an NSAID. Are we okay with every 6 hours for 48 hours? Yes. What is the max? 72. So she could have it up to every 6 hours up to 72 hours. But 48 hours is typically what is done. So we're good with that. The morphine PCA, she has a continuous rate of 0.05 milligrams per kilogram per hour. We're going to make sure that that is safe before we start that. When she goes onto a morphine PCA pump, what else does she need? Pulse ox. Continuous pulse ox. That is an understood order at Children's. I think it's with any PCA pump now, that the patient should be on a continuous pulse ox. So that's actually, we're going to be happy about that. We're going to constantly know now her pulse and her oxygen level. Type and cross for 2 units. Is that surprising? No. Warm compresses. Remember, we like warm compresses. We want them. We just don't want to burn her. Strict eyes and nose. That is appropriate. Why are we consulting social services?
To make sure she can get the help that she needs.
So
We might not have company there because her mom is taking care of other children.
So that's going to be Child Life. Child Life will come and play with her and entertain her. Social services, we want to get them on board. So if her problem is she can't get to her appointments, she can't get her medicines, they can help facilitate that. They can help the mom find the resources she needs. Now, when you consult social services to any mom, and when you're explaining what you're doing to any mom, especially a single mom who's pregnant, you're not going to start the conversation with, we've consulted social services.
No.
Because she's going to most likely hear DCFS is coming. So you're going to say something to the effect of, I noticed, or I heard in report that you have an automobile that's not always reliable. I know you're a single mom, you're working, you're pregnant. So what needs do you have? We're going to get social services to come and help you, but it's people that are going to come help you. And not that we are.
Social worker instead of social service.
You could say that too, yeah.
That is such a.
But sometimes because the social worker is involved in DCFS claims too. So you're going to preface it with, this is to help you. And then to get her, put her at ease. And then you're going to say the name, basically. Because parents do get very, as soon as they hear social services, they're like, wait, what did I do? You're taking my baby away. So just make sure that you present it in a way that's not scary, because she won't hear anything else that you say. And then Child Life, they come in, they have iPads, they have all kinds of things to entertain the kids while they are having procedures done or having IVs started, things like that. And then they'll come in every day and just play with them. So which order on here are we going to do first? The bolus. The 2 reasons. We can get that right away. Pharmacy has to get that. Pharmacy has to, release that, do all the you have to do equations. You can start this right away. And once we start that bolus, we're going to get blood moving. While it's not going to be the amount of hemoglobin that we want in the blood, at least it's moving. We're going to move it a little bit better. So that's going to be our first. We already have the CBC, so because you would want to assess, right? We already have the CBC. She doesn't have more labs ordered until the morning. We will want to, like I said, ask the doctor if we can check her CMP or BMP before we start the potassium. So that will be our priority, because also I was going to say circulation. So dehydration, circulation, that's how you can tie in your ABCs. Nothing on here is airway or breathing. Circulation.
So theoretically, by diluting the hemoglobin,
It's going to make it worse.
Anemic?
That's good. The anemia is going to go down.
Could you possibly put them into a respiratory crisis by doing that?
You could, but she's so dehydrated that probably won't happen.
Okay.
And all at the same time, we're getting this ready too.
Right.
So we're gonna bolus her. As soon as this is released, we're gonna do the morphine. As soon as we get the blood, we're gonna start the blood.
What do a medically monitored camp? Shouldn't this have been
Yes.
prevented?
Yes.
Like, shouldn't she have been?
Somebody failed her at her camp. Somebody was not making sure that she was drinking and keeping her cool. So they need their money
Under
back.
the medically monitored camp?
Nope.
She's back in the hospital.
Nope. And then why is pain control such a big deal?
Because pain creates stress and
We don't know.
It exacerbates.
Affects your vitals too.
Mm-hmm. So it's going to relax her. It's going to do what to her vessels?
Is it diuretic?
And get more oxygen. The little bit of hemoglobin we have can get there a little easier. Alrighty. So, not that bad, is it? That's all I have. Do y'all have any questions about that? Or yes.
it sounds silly because we did go over some prophylactic treatments like folic acid and the one I can't pronounce, the chemo pill. But is there anything else that after those 7 days? I don't know. I work in the ED and I see the same people and other people. I mean, there's constantly people in there with sickle cell.
Sickle cell.
So I feel like some of them don't do what they're supposed to do as far as like keeping hydrated. I feel like
Some do.
do, and they're still coming back. Like, I don't know. Is there any medicine that they
Just the 3.
just the 3?
So those patients would probably benefit from a stem cell transplant. If you're doing everything that you're supposed to do, if you're staying hydrated, then it's probably so severe because there are different varying levels of severity. So they may be good candidates for a stem cell. Or this new thing where they actually do gene modification.
So, I know in a lot of research it shows that vasodilators are just as effective at pain management as opposed to opioids. So, do you ever see them prescribing those?
I have not seen that, no. But it would make sense because we just need to dilate them
I work in ER as well, and we have a lot of people who are very addicted
to the.
It's very young.
It's sad. Like we in clinical on Friday, we were giving a 22-month-old morphine every 3 hours
I mean, we have people who come every single day
for Dilaudid.
and they get prescriptions and go through it in a day, and we can't manage them through the ER.
No,
They
you
come
can't.
at nights, we don't have case management or anything.
So they just get there.
They
They're
get the-
Dilaudid
Yeah.
That's frustrating.
because they are in pain, but they're also addicted.
Addicted, right?
And they're young.
And is it sickle cell patients or?
Mhm.
There's probably like about 15 or 20 that are there at least 10, 15, 20 times a month.
That's crazy.
And
It
they
is-
go to all the ERs because
They
So
shop.
they shop, yeah.
Yeah.
It's so sad. It is a problem, and I think like we know it's a problem, but it's like we don't know.
there's so much that like the drug companies do, and like so when I was first like dealing with this, I was doing all this research. I was like, oh, vasodilators like are just as effective as opioids at decreasing the pain. So I don't understand why they're like
If it just is
normotensive,
effective.
like can we just give them,
Then yeah, then that would make sense.
but we don't see.
You'd have to like start that
when
as a
they're
baby,
younger, yeah.
basically. So which medically it makes sense.
Yeah,
So if they could just do that
instead of
starting them on them,
There's so much.
it's like we've just created a big monster.
there's
Yeah.
also like a lot of people who end up becoming drug users for
Uh-huh.
their parents, and
Hmm.
it's
It is. It's like it's like beyond fixing now. You have to start with this new generation, basically.
Yeah.
I was
Because
just wondering if you saw that. Like,
I have not, but it makes sense.
populations, like,
at Children's, they are still with 1-year-olds putting them on morphine.
I mean, like in our ER, they try really hard to like not, allow them to keep doing this. So they'll be like, oh, I'm gonna do a Cortisol shot, and then usually they'll just leave.
They'll just leave.
The ER.
So they can get what they want. I know, I mean, it's addicting, so obviously a lot of it is there. Is that, so we've created a beast.
I'm not sure if I signed the roll.
Where is the roll? Or
Today I know I
yesterday?
said, yeah, from yesterday's. Probably like the last one or the second to last one. Yep, I did not.
We get infection today and Monday, and then we get something for test 4, and then our test is the 7th.
Did everyone sign yesterday?
Just going blind.
Well, they really could have just not had today.
Miss Matthews will start at 9.
And then texted us on Tuesday. They pushed it back a week. They just given us one extra week. Great on the wheel.
This creates anxiety for me, so I bring it in small doses. This is just this test, this is everything. I have a giant binder like this. No, I get it.
Yeah, I had a transfer binder.
Do y'all have any other questions?
This is all this test. When this test is over, I can't drag this around every day.
I'm so used to it.
Yeah, that's what, yeah.
Yeah.
I remember, yeah, I just,
I do,
this lady, I have patients, and she would just talk, so that's just the right.
Yeah, there's no doubt. Yeah. Straight lecture.
I just say, of course, it's like,
So I've had
Level 1, I used to go home.
I have a binders like this.
I'll type it like two fingers. I'm like, just type it. I'm not just right. So now I just do like signs. medications, risk factors.
Yeah. She's got a photograph.
I also, so
Yeah.
I'll work for PJs.
So I highlight grants
Yeah.
after what I'm
Your
saying.
basic.
This test is doing really good. It's gonna take time.
don't work for therapy. Yeah, it's still, I like to all the places where you want.
It's kind of like an European. So like basic, it's actually only like 2 months, 3 months.
Right.
Paramedics, like nurses, like it takes 2 years. And they're so they can do certain.
I mean, if I have an activity, so they can do
I
I mean, yeah, we don't have cameras. And I've gone with paramedics who taught me, and they taught me a lot of things. So technically I can't speak, but
Like, I remember, like, in EMT school, like,
My wife, she told
they
me
taught us how to
some of like
Yeah.
ER children's.
yeah, I learned everything on the field. Yeah, because I mean, sometimes
Yeah.
like our partner is doing one thing,
Yeah, yeah, we have
and
that in
it's
the
a
US.
time crunch. And then they'll be like, okay, hurry up and do this.
but, paramedics can also do EJs, which nurses can't do. So the scope of
Hey.
cases is like,
How are you?
but nurses can.
Good. I had fortunately last week a student when I was lecturing asked me where team 3 was supposed to be when we were doing 1 and 2, and I said right over there where we were yesterday, and she goes, no, it's not, and I said, oh, I don't know. So I texted. That's why I texted the group. Whatever it was last week, and Bridget put 107. But it's really 102. So I was going to 107 today, and I looked in this door, and I was like, those are definitely my students.
That's what I just told you. They should not be so weird. They're so weird, and I'm so weird.
So I was like, let me tell the pilot just in case, because I did not know. And in case the door was still closed, I didn't want to. I told him to be back by 9.
Okay.
It's down.
I love coming after Amy because she always knows I gotta go. Because me, I would be like,
What do I do? I think I just started 1 or 2 semesters before you, so I still feel new too. So I'm like, okay, if I'm lost, then she's lost. So.
and you're exactly.
And then you saw too that Jen left. Jen went to be assistant dean, so I'm like, and that was my second semester. So I was like, still test. I'm like, Jen, you left. What am I supposed to do? It is.
I didn't sign the roll for yours.
You'll be like setting down.
It is. Well, good luck.
Thank you so much, man.
That's literally how it is.
She's gonna speak her. Thank you. Tying up those, and the orthopedist walks in, and she looks like she's like this really nerdy, like cool doctor. She goes, "You look like cancer," and like, and then you have that guy with like the self-Pharisees, so he's like always bumping like leaders and push, and they had to do like an airway or something, right? So they gave him ketamine. Yeah, they gave him ketamine.
He didn't speak English.
They used to call it, hey,
Yeah.
Speak English and all.
And then all of a sudden, and then also he went, I'm drunk. I am super drunk, and then
And then they just.
they hit the case. But it's super safe. It's safe in elderly patients. It's safe in kids. So it's one of the safest.
Just not in a recreational
It also,
purposes.
it actually is very good at treating,
And the reporting.
my psychiatrist is already intravenous.
I could see why that would be. I think only one medic did it. Has used ketamine.
Yeah, well, They used to our son.
Oh, really?
We won't have it.
They can, I think we do, they have, y'all have to do research. Yes. They, well, so the same thing, so like broken protocols, they can only do research.
Yeah.
Slow in the morning until lunchtime, and then the water starts piling in.
Yeah, so.
I've been working.
I tried making one.
But he got fired. He's working for me now.
When you were,
I work for me. We work at a I'm so sorry. We work at Option and he's still in ambulance.
No, I almost did. I think I was hired on and I did it in 2 days. And then I was just, I was like, screw this. And then I started working Brenda called me that day that I quit. I like that. I live in, but Brenda called me and I was like, and our call volume has gone up this week, backup service, West Jeff, and backup. So I'm like the West Bay. Oh, West Waco doesn't, they don't. Yeah, Brenda's pretty busy. I think the last day I worked, we ran 11 calls. It was It's not that great. It's not that great. I actually stay on the service if they do well. Exactly. They start at 15. You didn't like her. Like her. And we're the lowest paid. Yeah, we're the lowest paid. Yeah, we don't get any of that because we're
All right, it's 9 o'clock. We're gonna get started. If you all wanna put your recording devices up here, you're welcome to do so.
Thank you.
All right, so good morning. My name is Miss Matthews, and today we're going to be covering infection. So we're going to start with otitis media, and then cover meningitis, neonatal sepsis, measles, mumps, rubella, and varicella. Now, not all in an hour, but y'all have a part 2 to this, so we'll, however far we get to, we'll pick back up next week, okay? So what's otitis media? It's an inflammation or infection of the middle ear, and it typically happens because of a dysfunction to the eustachian tube, okay? What happens is that middle ear becomes blocked with fluid, or it swells up from the infection. It can be bacterial or viral in origin. Some bacterial causes are on the slide, like Streptococcus pneumoniae, H. flu, and Moraxella catarrhalis. Some viral causes are RSV, rhinovirus, and like your common colds. Most of the time, it's children who get otitis media, but some adults do. The peak age is 6 to 18 months. So here you'll see a comparison of what the normal ear looks like and the one that's infected with otitis media. So the viruses and bacteria come through the eustachian tube, enter through the eustachian tube, and then all that fluid settles behind the eardrum, and that's what causes otitis media. There are certain factors that predispose children to otitis media versus adults. So children have a more shorter horizontal eustachian tube, so it's going to get blocked easier. As adults, ours is at an angle and it's longer, so it easily drains. Otitis media is more common in the winter months. That makes sense, right? Because that's where you have your increased cases of flu, colds, and viruses that are around. Children who are in daycare centers are more at risk, and those that use pacifiers for extended periods of time are also more at risk for getting otitis media. Comorbidities like cleft lip, cleft palate, and also Down syndrome, because those muscles that operate the soft palate and eustachian tube opening and closing, they're dysfunctional in that population. So that's why they're more predisposed to that. There has been some research that says breastfeeding is more protective against otitis media. I will say I breastfed my kids up until 1 year age, and they didn't get as many ear infections, but they still. But research says that breastfed babies are not as at risk. There's also with otitis media an increased risk of meningitis, and we'll talk more about that later when we get to meningitis. So what signs and symptoms would you all expect to see in your patient with an ear infection, a middle ear infection? What would they present with?
Drainage.
Mm-hmm.
Pain.
Pain, yes.
Crying.
Yes. So I'm glad you said that. So a small child or a toddler may not say my ear is hurting if they're not talking. But what might they do? Pulling at the ear. Yes.
Balance issues?
You can if the fluid is severe behind there. That you can see that.
Speech delays.
Absolutely. Yes. Very good. So inside, when you do your, when you look inside with the otoscope, the eardrum is going to be red and bulging. And like we said, those small children, they may be pulling at their ear. They might not say my ear hurt. Or when you lay them down, especially if that affected ear is the one that's down and not up, they may be like restless or irritable. And you're like, what's going on? But that hurts. That puts more pressure on that eardrum. A fever is one. My daughter had double ear infection. That's the only symptom she had was a fever. She didn't pull at her ear. She's 2 years old. She didn't pull at her ear. She was not fussy. Nothing else. No other symptoms but a fever. I just could not break the fever, even alternating Tylenol and Motrin. And so that's why it's important, because some of these children, they will be asymptomatic. So they may just be going for their regular child visit, and then they are diagnosed with ear infections. But it's important that we still treat it without symptoms, because it could lead to those speech delays and things like that. And you don't want the ear infection not to go untreated, even if they're not symptomatic. Also be aware of ear pain that suddenly stops without any type of intervention. It's not because you gave the Tylenol or the Motrin. It just, the baby's ear was hurting or the adult's ear was hurting, and now it suddenly stopped. What might that indicate?
Blocked eardrum.
Yes. Wait, what did you say? Not blocked eardrum, rupture.
I said popped.
Oh, popped. Okay, I'm sorry. I thought it sounded like blocked.
Sorry.
Yeah.
Not a good nursing term.
Yes, the tympanic membrane has now ruptured. Now that fluid has some place to drain. Not a good thing, okay? That's an emergency, and they need to come. That needs to be addressed. All right. So normal eardrum and infected, like we said, the normal eardrum, you can see how it's paralyzed or grayish looking color. You can see all the structures. And when you shine the otoscope in there, you'll see that cone of light. But then here, the affected eardrum is red, it's bulging, it's distorted looking. The picture on the bottom, it could even be retracted because of that fluid behind the ear. So it may not be poking out, it may be like it's sucked in. All right, so diagnosis is made with the signs and symptoms that the child presents with. You also want to ask what kind of home remedies, what have they tried or given the child to treat this infection at home. That's going to be important too. The history, is this the child's first infection, or do they are they getting these recurrently? Because recurrent otitis media is considered 3 or more infections in a 6-month time period, or 4 or more in 12 months. Where are they?
In the hallway.
In the hallway? Give me 1 second. I thought it was.
Yeah. 3 or more.
4 and 6 months and 4 or more in 12.
Sorry about that.
Thank you.
Thank
you.
All right, so then the clinician, as nurses, we don't do. Oh, yes, question.
Ruptured eardrum, it grows back? Like, it's not ruptured forever, is it?
No, we're gonna get into that too. Good question, though. Good question. All right, so the doctor, nurse practitioner, physician assistant is gonna do direct visualization with the otoscope, looking inside, making sure you see those landmarks and what the eardrum looks like. If you do see ear drainage in that ear canal, it is culture, but it's not always there, y'all. Then you'll send that off for culture and sensitivity. There are 2 tests that are done by trained clinicians, either an audiologist or a ENT doctor. That's tympanometry and pneumonoscopy. So with tympanometry, they use a specialized scope that all it does is it emits a tone, and then it comes out the results on a graft. With pneumonoscopy, they inject air into the ear, okay? With otitis media, because that fluid is there, in both of those tests, you're going to see decreased movement. The eardrum is not as mobile as it should be. And so that would indicate that there's fluid behind the ear, possible infection. So how do we treat otitis media? Antibiotics. What else? Eardrops. Occasionally. What kind? Bacteria eardrops or? Antibiotic, like.
Amoxicillin.
Amoxicillin. So initially, y'all, we do supportive care. If it's a non-severe case, we watch and wait for 48 to 72 hours. We do not give antibiotics initially. If, like I said, if it's a non-severe case, my daughter did get antibiotics because we were past that window. I was trying to treat her at home, and so giving my history to the doctor, we had passed that 48 to 72 hours and she wasn't getting better. So we did get them. But if you catch it, like if a mom brings the child in, as soon as the symptoms are presenting and we're in that time frame, then they may just watch, because it may resolve on its own without any treatment.
So it has to be after 72 hours to be prescribed antibiotics?
No, anywhere between 48 to, because it could be 2 days and they may give it. Yeah. They may wait 2 days.
Between 48 and what?
72. Initially, you try to wait. Does that make sense? Like if the child is presenting, they just had these symptoms for a day. The doctor may say, let's give it a while before we give antibiotics. Yeah. But if these symptoms have been going on for 4 or 5 days, we're not going to wait an additional 2 to 3 days. Okay? And then if it doesn't get better, so supportive care, let's talk about that. What kind of medication would we recommend? Tylenol, Motrin for the fever, or even for analgesic for the pain. And eardrops, they may be steroids just to help with the inflammation in steroid form. Non-pharmacological measures would be having them to make sure that their ear is elevated as much as possible, the one that's infected. So a child laying down for a nap or at nighttime, if it's their right ear, laying them down their left side. A warm compress, a heating pad. Having them chew gum or blow in a balloon. That relieves some of that pressure. the child is not improving, none of that's better, then we proceed with antibiotics.
What about like pacifiers and stuff like that to chew on,
Mm,
No?
no, that's not recommended. Our first line will be amoxicillin. And then if that's ineffective, they've been on that for a few days, still symptomatic, not getting any better, they may switch to amoxicillin with clavulanate. The trade name for that is Augmentin. What was that about?
I have tubes in my ears.
Oh.
My brother
Yeah,
has, my
same.
my godson, all the tubes.
Yeah.
Prone to ear infections.
Same.
Oh.
They have some weird ears.
If they have a penicillin allergy, we can't use either of those, okay? So
Yeah.
cephalosporins may be an option, Bactrim, azithromycin is something they may go to. If the child is less than 6 years of age, the course treatment is 5 to 7 days on antibiotics. If they're older than 6, I'm sorry, I messed that up. If they're less than 6 years of age, it's 10 days. 10-day treatment of antibiotics. Or less than 6 is 10 days of antibiotics. And if they're 6 or older, it's 5 to 7.
6 or older.
Mm-hmm.
Yeah, she just said she missed it.
I switched it.
Yeah.
I made a mistake the first time. Got it? Okay.
So
Less than 6
is
is
the
treatment.
treatment.
6 and 8.
All right. For children who continue to have ear infections, recurrent ear infections despite antibiotic treatment, or otitis media with effusion, that just means fluid is in their ear, but they are having hearing loss. These are candidates for tubes in the ear, okay, the tympanostomy tubes. So surgical management of otitis media can either be a myringotomy, which is an incision in the eardrum. That can be done as a standalone treatment. Typically, it's not. Typically, you get a myringotomy with tympanostomy tubes placement. But if there is concern about mastoiditis, or like an impending cranial condition, CNS, which is central nervous system, then they may just make the incision just to drain. But typically, it's done with the tube placements, okay? So nursing management with a patient who has their tubes placed in their ear. You would advise them to use earplugs when they're swimming and taking showers, because you don't want that excess water to get into the ear canal. You want them to report any purulent draining while the tubes are in and fever, because that will indicate an infection. If the tubes fall out, what do you do?
It depends, how long have they been in?
Just shove them back in there.
No. They typically fall out within a year. But even if it's less than a year, it's not a medical emergency. You can call the doctor to inform them, but you don't have to present to the emergency room. You may not even be seen by the doctor. They may just monitor the hole that's made. So to answer your question about the eardrum being perforated, it also goes hand in hand with tube placement. So sometimes they don't put the tubes back. They just monitor the patient, continue to do ear exams, and give them a time frame for it to close up on its own. But if it doesn't, then they take tissue from either behind the ear, in front of the ear, and close it up with a flap.
I know this may be a silly question, but if you get tubes,
Mm-hmm.
do they stay in forever?
No.
They eventually just fall out.
They should, but you can also, if they don't fall out and if they're staying in longer than the doctor, the ENT recommends, then you can also have surgery to have them removed.
Okay.
So they're not very big. I mean, you
No.
see them come out.
That's what they look like, and you may not. I have a goddaughter who's 2 years old. She got two. Some mother did not know. One of them fell out of her ear. She didn't know till she went follow up for an ENT. And he looked in there and didn't see it. She doesn't know when it fell out, how long it's been out, or anything like that. So you may see, you may not.
Yeah, I can't imagine your ear canals.
So that's a picture of what it looks like.
I'm still wondering how it can just fall out.
Well, the patient's anatomy is different. So may not have closed over it like it should. So once these tubes are inserted, is that going to stop the child from getting ear infections?
No.
Absolutely. Nope, it will not. If they do continue to get ear infections with the tubes in, it's important to note that oral antibiotics won't be prescribed. There will be eardrops. Because now we have direct access to the source of infection. So now we don't have to take something by mouth that's going to cause could possibly cause systemic issues. We treat right to the source. Now we have these tubes. I also want you all to review the steps of administering eardrops. That's in your skills book, your volume 3. So be mindful of that. I know it might have been some time since you've had to do that or remember.
So the initial, like, amoxicillin is gonna be by mouth.
It's still. Yes, ma'am. All right. So going back to patient education, you want to, even preventatively, babies should be fed in an upright position. No bottle propping. That's going to put them more at risk for ear infection. So that might be something you have to tell the parents. You try to encourage them to discontinue the pacifier at 6 months of age, but if you have children, you know how difficult that may be. And they should definitely avoid use at sleep time, when they go to bed. Try not to use the pacifier. Important to avoid tobacco exposure to tobacco smoke. Encourage breastfeeding if the mother can. They should avoid air travel when they have these infections. That's just going to make that pain worse.
My friend's son had such bad ear infections to the point where if he was in a car, he was screaming, crying.
Really? Even
Screaming, crying. Like, poor little nugget, once he had tubes in his ears, he wouldn't shut up with actual words. Because before he was speaking caveman. And then it's like his ear, he got his tubes, and then it was like, may I have the bread? And you're like, that's what meant.
Yeah. But think about it. Children learn from you talking to them. That's how they get their language.
It was like that extreme.
And if he can never hear, or it always sounds like y'all are underwater, then that's going to affect their hearing too.
Same thing. They got his tube, and he was like, "I'm like, you're too loud."
Now he can hear.
Like, he was very loud because he couldn't hear.
He couldn't hear, right?
And when he got him and everything, like everywhere we went, he was like, "Oh, too loud." Everything was like.
I know a child that they were working him up, thinking that he had some kind of developmental delay.
Yeah,
but all it was couldn't hear. Ear infections that had gone untreated and he couldn't hear. So that's a good fix, but to think like they thought it was something else, but it was just simple ear infections. And always teach your patients to continue that full course of antibiotics, not only when symptoms start to resolve, but the full course, 10 days, even if the child is feeling better or the adult is feeling better. All right, so there is a page in your PEDS book, 458. It talks about the care of the child with tympanostomy tubes, care after surgery, and care following the post-operative period.
You said 468 or 58?
5'8", 4'5'8". Mm-hmm. So these are some common terms that are associated with otitis media. The first one, otitis externa, is also called swimmer's ear. So that is just when the ear canal is irritation of that skin and the surrounding tissue of the ear canal. It can be infected with a bacteria, virus, or fungus. Some common causes: foreign objects being placed in the ear, cotton tip applicators, and even hairsprays. Interesting, huh?
Yeah. That's understandable.
You just spraying your hair and the residue is just settling in there. If you don't clean your ears that well or daily, it's just caking up. Yes.
So does the like rupture of the, or I guess not rupture, but like incision of the eardrum to put the tubes in and then falling out and closing up, does that put the child at risk for hearing loss?
With the tubes?
Or just like in general, the eardrum having to like be open and then close up later?
Not typically, no. More so at risk if their ear infections are not treated. Mm-hmm. But so that one typically that procedure is just done one time. Tubes. You may have to get tubes reinserted, but a ENT would consistently keep making incisions, putting tubes in and out like that. Yeah.
Okay.
So one procedure, no.
Okay. But if it was like multiple traumas, then it may.
Yeah, then it may. I can see you definitely doing that.
Okay.
Yes. Otitis media effusion. And so we briefly talked about that. That is when fluid's behind the eardrum, but it's not infected. Okay, there's no bacteria there. So we get the cold. We may get a cold, and our ears are stopped up. Fluid's behind. That's what that is. Okay, otitis media with effusion. So physical exam. When you look inside the ear, you may see air bubbles on the eardrum or fluid lines. Remember, the fluid is not infected, and so you don't treat that with antibiotics. Allergies too can cause, if you suffer from allergies, your ears be full.
Front speakers weren't working because my ears were clogged.
That
I
clogged
could hear
them.
the music in the back of my car, but not in the front. But now my ears are better and I can hear the music everywhere.
Y'all are too funny.
It's gonna explode.
Mm-hmm. So the table in your piece book, 19-7, does a very good job in comparing and contrasting otitis media with effusion and just acute otitis media. Has anyone ever heard of a cholesteatoma? No. All right. So it's not a tumor or anything. It's just a skin-lined cyst that's in the middle ear. Usually only affects one ear, not both, and it causes an obstruction. So these patients have to have surgery to remove that cyst. Yeah, it's a skin-lined cyst. So not a tumor or anything cancerous.
Okay.
Mm-hmm. And it typically invades that middle ear and the mastoid bone. So these patients undergo a mastoidectomy where they have to have that bone removed too, and then the cyst. So before I do this review question, we talked about wearing earplugs when you swim or you shower. So there are some surgeons that say swimming is completely off limits. And then others will allow you to swim if you're wearing the earplugs. I mean, they just advise you to wear earplugs. So sometimes swimming is not completely contraindicated. You all know different surgeons have different ways of doing things. So, with that being said, the nurse is caring for a patient who has undergone a myorrhizotomy and tooth placement. which activity of your choices should this client avoid while the tubes are in place?
Swimming.
All right. Any questions on otitis media? Pretty straightforward, huh? All right, moving on to meningitis. So meningitis is infection or inflammation of the meninges, those 3 layers of the membrane that cover your brain and your spinal cord. The subarachnoid space and the cerebrospinal fluid too can also be infected. Also, you may have involvement of cranial nerves 3, 6, and 8 with meningitis. And we're going to talk about what that looks like a little bit later when we get signs and symptoms. So remember, with meningitis, the bacteria, virus, or fungus invades the meninges and causes the brain to become inflamed and swell. Why are newborns or infants most at risk for this?
Because their skull is pliable, maybe?
That's a good thought.
Because
Well,
they come out and had almost a head trauma.
no,
They don't have an immune system.
Yes.
that's right. He said their immune system, well, they have one. It's underdeveloped. I knew exactly what you mean. It's underdeveloped, so that's going to put them more, have them more susceptible to infection. So meningitis can start from a source within the central nervous system, or it can come from a secondary source. So we talked about how otitis media can lead to meningitis. There can be transmigration of the bacteria from the ear, the middle ear, to the brain. Endocarditis can lead to meningitis. Pneumonia. Patients who have VP shunts.
Oh, that makes sense.
That makes sense, huh?
Yeah.
Yeah. Because where is it?
Right in your head.
So easy way for bacteria to travel. Pneumonia as well. Some trauma like a skull fracture, that makes sense, can lead to meningitis. And although we do lumbar punctures to diagnose meningitis, someone can have a lumbar puncture for another neurological condition and you can have meningitis from that. Very important to have, sterile technique and all that, keep the area sterile, because you can cause someone to have meningitis.
I'm sorry, just to clarify, the Piamator, the arachnid, it can be in any of those 3 spaces.
Mm-hmm. Yes. Also, patients have central lines and ports and also chest tubes. So invasive procedures can lead to that. How is meningitis spread?
It can be airborne contact.
Viral or bacterial, both?
Both.
Yeah.
They both spread the same way. So it doesn't matter. Droplet, yeah. And the incubation time. So from the time someone is exposed to you see symptoms can be anywhere from 3 to 7 days. So think about that. It could be a week. How many people have you seen in the past week? Exactly. And you may have the symptoms or you may not, but then you think about all the people that you may have infected in that time. 3 to 7 days. It can be anywhere from that time. And the patient is considered contagious. So once, I will get more into that. Once you start treating them with the antibiotics, 24 hours after the effective antibiotic is started, that's kind of when they're no longer, but we still, if you'll see in any hospital, they still maintain droplet precautions until they're discharged.
Is that with all antibiotics? You're contagious until like the antibiotics have been in you for 24 hours?
Because it depends on the disease,
Yeah.
right? Because with otitis media, ear infection, I can't pass that to you.
Right.
Yeah, I can't pass that to you.
What about like the flu?
Well, you take antivirals with the flu. Sometimes, and sometimes they don't. You have to be within that time period. I think it's like 24, 48 hours, and some doctors won't even give you like the Tamiflu and things if you pass that. So 2 most common types of meningitis are bacterial and viral. And we're gonna compare those two. So bacteria is a medical emergency, you all. It has a very sudden onset and can cause serious illness, even death, within 24 hours. It can quickly lead to severe complications like shock, DIC, seizures, and death. Common causes I have listed on the slide: H flu, type B. That was the same thing with otitis media. One of the bacteria causes. Strep pneumoniae, same thing with otitis media. Neisseria meningitis. So those are common bacteria causes. And y'all, before the, so we have seen a decrease in deaths with kids under 5 due to the H flu type B vaccine, because meningitis, bacterial meningitis, used to be the leading cause of death in that population before the vaccine was made or discovered. So with bacterial meningitis, the cerebrospinal fluid is going to look cloudy in appearance, and when tested, it's going to have a larger content of bacteria. Now, viral meningitis, its onset can be abrupt or gradual. Can be caused by mumps, measles, herpes. Seizures are rare with viral. They can still occur, but you'll most likely see seizures with bacterial meningitis. And the cerebrospinal fluid will look clear, and of course, it wouldn't have any bacteria there. So let's think about how the body works with the brain. So this is an infection in the brain and spinal cord. So think about what symptoms the patient might have. Yep, absolutely. What else? Headache. And what are those?
Malaise,
Give us an example.
fatigue.
Yes, malaise, fatigue. That's what he said. Did y'all say fever? Yes. What about, and you said loss of the level of consciousness may be altered, but they may be hallucinating, they may be delirious, because all that makes sense. That's our brain, and so it's affecting how it works.
Stiff neck.
Yes. So, depending on the age population, we're going to talk about that. Children and adults will likely present with 2 of these 4 symptoms, and those are fever, headache, nuchal rigidity, or neck stiffness, and altered mental status. They may have all 4, but they will most likely have 2 out of these 4 when an older child or an adult presents with meningitis.
And this is bacterial and viral?
Huh?
Bacterial and
Yeah.
viral?
Bacteria and viral, right. Additionally, they may be nauseated, they may be vomiting, have sensitivity to light, which is photophobia, double vision. But the infant may or may not have those classic signs and symptoms where it'll be hard to tell if they had a headache anyway within an infant. But the neck stiffness may be there. What we may see in the infant, they may have a fever or they may have hypothermia. They won't be feeding well, a high-pitched cry. We're going to assess their fontanelles, and they most likely will be bulging because of the increased intracranial pressure. Same in adult, child, and infant. This particular purpuric rash, we're going to get into that a little bit later, but that's usually only seen with a certain type of meningitis, which is your meningococcal meningitis, that rash. Mm-hmm.
Can you go over the Carnegie sign?
Yep, we're going to get to that. Yep. Important to note, if you have an infant that is dehydrated, the mom tells you they have been vomiting for the past few days, is their fontanelles going to be bulging? It's going to be depressed. Yeah, it's going to be sunken. So it may be hard to miss. It may be hard to grasp that their intracranial pressure is increased because you assess their fontanelles is sunken. But the mom just told you that the baby's been vomiting. So keep that in mind, you know. It's not, you have to take all of the data that they give you. So exam findings. So these, in addition to signs and symptoms, diagnostic testing, these are 2 tests that can be done at the bedside that are indicative of meningitis. The 2 slides or the 2 pictures on top is Kernig sign. So the patient is going to be in a supine position, laying on their back. Their leg is going to be flexed at the hip and the knee. The patient or either the clinician will try to extend the leg at the knee. Usually this doesn't cause any pain or resistance. But with meningitis, the patient will have pain, or they may not, or when you're doing it, it's hard for them to stretch it out because they have resistance there, so they won't do it. They'll stop. So that's Kernig sign. With Brudzinski, which is the 2 pictures at the bottom, same supine position. The patient's neck is flexed. Normally that wouldn't cause your hips to come up. They wouldn't cause flexion of the hips or knees, but with meningitis it does. It's an involuntary motion that happens with meningitis. Got it? So
Wait a minute, you pull up her neck,
Mm-hmm.
her knees come up?
Mm-hmm.
If they have
meningitis. Because normally I could lay you down and do that and your hips and knees won't do anything. They'll remain straight. But with meningitis, they come up.
Like they'll withdraw and retract, like she'll pull her knees up.
She's not doing it voluntarily. It's an involuntary movement. Mm-hmm.
Compensating for the lack of range of motion.
Mm-hmm.
And the second one was called what?
The 2 pictures at the bottom,
Yeah.
Brudzinski's. BRUD ZINSKI. So other signs of cranial nerve irritation, you might see a patient might have nystagmus. Y'all remember what that is? That rapid eye movement back and forth. Ptosis, where the eyelid droops. Yep. And we talked about double vision, sensitivity to light. They may either have vertigo, ringing in the ears, or be deaf. Have hearing loss from meningitis. And the deafness that occurs in meningitis is permanent. whether it's partial or complete, it won't come back because it's sensory neural. So there's no way to get those nerves back. Now with otitis media, it's a conductive hearing loss. So when we treat the problem and we remove the fluid, now that the sound and things can vibrate off the eardrum like it's supposed to. But with meningitis, nerves are involved. So they either will have partial or complete hearing loss. So in an infant, you may see them lying in. Now they won't be in the air. I told they won't be in the air like this, but in their crib or bed, they may take this position. It's called an epistotonic position. So it's a state of severe hyperextension and spasticity. So their head, neck, and spinal column are in a complete arch, bridge in an arching position. They're trying to relieve that pressure that they have in their head.
Say that word.
Say what this word is? Epistotonic. So you couldn't do Kernigs and Brodinski's on the infant, but they may be in this position. And you'd be like, oh, that's an ominous sign. Meningococcemia, this is nothing but sepsis due to meningitis. It's gotten pretty bad when you see this rash, y'all. So the rash starts off, it's a distinct urticaria, so there's itching involved. Rash that starts off as petechiae, and then they progress to purpuric lesions, so those larger lesions. The patient may be fatigued, tachypnic, cold hands and feet, chills, severe aches and pains. And most likely they're going to have their limbs amputated. Very, very sick. If they survive this.
That's just lower extremities or all?
Oh, no, all. They can affect all. The rash can be all over the body. But the extremities, they may amputate.
Is it just the affected ones with the rash that would mean, or just cut them all off?
Oh, no. That's what you said. Well, they would do, if there's no blood flow and they're pretty much dead, then no circulation, they'll cut it off. Whichever one. And like I said, if they survive this, they may not even.
This happens if it's like untreated.
Huh? Not necessarily untreated. So you have to think about everybody that gets meningitis is not a healthy individual. They have other comorbidities going on, so that can affect the way they progress to sepsis versus your young, your individual who's in a great state of health. So yeah, it doesn't mean that they're not being given the right antibiotics. Other things could have been factored in that caused them to progress to sepsis. Whereas somebody else got their treatment with meningitis, got discharged, and yeah. So how do we diagnose meningitis? We do a lumbar puncture, and that's to assess the cerebrospinal fluid. So what you will see in bacterial meningitis, we talked about, it'll be cloudy. It'll also have bacteria present, but the glucose content will be low. It will be decreased. Most of the time, half of what your blood glucose is, the patient's blood glucose. Anybody know why?
The bacteria is using glucose?
Yep. He said the bacteria is using the glucose, and that's exactly why.
I need your brain.
Mm-hmm. That's exactly right. The protein, y'all, will also be elevated. So protein content will be elevated. Bacteria will be elevated. It will be cloudy, but the glucose is going to be decreased. And when you compare it to the blood glucose, it'll likely be half of that value, whatever that value is. So in contrast, the CSF fluid for viral will be clear in color, no bacteria, and high or normal glucose. Yes. And the protein content may be normal as well.
So can you determine anything from a viral lumbar puncture?
What you mean? Well, you.
All those are negative signs, like the.
So would you have to do?
So you're just doing one lumbar puncture and you're evaluating to
Right,
see.
but for viral meningitis, like all the signs that you've shown are signs of a normal, like clear lumbar puncture. Right?
So
are
the
there any
treatment-
positive determinations for viral?
No, but when you think about it, bacteria is the most serious and the one that's gonna cause the most issues is a medical emergency. So viral, meningitis, and I'm kind of getting ahead of myself, but meningitis, anybody presenting with it, we're gonna treat it like it's bacteria. We're gonna give the antibiotics because if it's viral, what harm did we do?
Right.
But if we treat it bacteria like it's viral, that patient's gonna die. And so viral is usually treated as bacterial meningitis until confirmed that it's a virus, and then it's just supportive care.
Okay.
So it's really not, detrimental. So we still treat them aggressively. Other things we'll get is blood cultures. So we'll get that before we initiate the antibiotics, but we're not going to wait for those results to come back because they take 48 to 72 hours. So that will just be treatment with a broad spectrum. And then, of course, we're getting a CBC with differential, looking at those things. Why are we getting a metabolic panel in chemistry? Why would that be important? What's that going to tell us? Good job. Yes. Kidneys and liver function. If they're on antibiotics and those two organs are being affected, we may have to adjust antibiotics. It's also going to tell us how they're going to get rid of the medicines. So BUN, creatinine, LFTs are looked at, and also the blood glucose to compare it to the CSF fluid. Very good. And then that just makes sense to get a CT and MRI because we're looking at the brain, the swelling and stuff. All right. That's the end of part 1. Y'all have any questions? Cause y'all it's 9:50.
Yeah.
Okay. Some of y'all was looking like, what?
We're into it.
Oh. I was like, it is at 9:50. Yeah.
I was telling her. She stopped. That's probably why we looked at her.
Oh, okay. If y'all didn't sign the roll, it's here.
Is that for both classes?
Yeah. Yep. Nope. If you signed it for Miss Onstead, it's the same one. That's the one I'm gonna take. Y'all don't forget your recorders and your phones. I'll see y'all next week.
Thank you.
Have a good day. Rest of the week. You're welcome.
I have a question.
Okay, come on.
So, like, this with the viral and bacteria.
Hold on. Okay,
When you think of how to present the question, I'm sorry. It came when you were talking and then went away. I'm so sorry.
No worries, no worries.
I know bacterial and treat rapidly. With viral, like I put this big confusion with treating bacteria with viral, right? Because I know that viral is non-living. It's a non-living so it has to infect the cell. So my question is, when viral meningitis, is it not presented in bacterial colonies or is it infecting the actual human
I went with me.
Bye.
Like, you know how Colin was, bacterial Colin was a girl.
Gotcha.
And then the virus
Thank you. I'm gonna put mine on it too.
Yeah. I was asking her how was it yesterday.